National Seminar Series for Geriatric Psychiatry. My name's Jess Friedland. I'm a geriatric psychiatrist and the program director at McGill University. And today, the topic is about kind of bread and butter geriatric medicine. And we're fortunate to have Dr. Carolyn Pavoni, who is going to present for us on that topic. She's an assistant professor in the Division of Geriatric Medicine here at McGill University, where she completed her undergraduate medicine training, her internal medicine residency, and her geriatric medicine fellowship. And she went on after that to complete a fellowship in dementia and behavioral and psychological symptoms of dementia at Baycrest Health Sciences in Toronto with Dr. Morris Friedman. And her main areas of interest are neurocognitive disorders and BPSD management. So it's kind of a perfect crossover between geriatric medicine and geriatric psychiatry, and who would be better served to kind of tell us what we as geriatric psychiatrists really need to know about from geriatric medicine. So thank you very much, Dr. Pavoni.
No problem. So you can hear me and you can see my screen, right? Thank you for that introduction. So as was mentioned, this is, I think, the third time I'm giving this presentation now. The goal of the presentation is to really teach you about geriatric medicine, the basics of geriatric medicine that you might come across as geriatric psychiatrists. So talking about the main geriatric syndromes, as we call them, that you may not have learned about up until now. So we won't focus on mood disorders and cognition, which I'm sure you'll be getting other lectures on. It's really to talk about the things like, falls, polypharmacy, urinary incontinence, frailty, elder abuse, and what we as geriatricians do when we complete the comprehensive geriatric assessment. So just quickly, I'm not going to spend too much time on this. I think we all know at this point that the geriatric population in Canada is growing. And so the need for individuals with special training in geriatrics is rising. And just to show that the projected numbers by 2041 show about 25% of the population will be, considered seniors, and about 6% of the population will be 85 years old and older. So the very old of the older patients that we see. And so what is the geriatric population? It's typically dealing with individuals 65 years old and older, but really depending on the institution, some of the geriatricians will see more 75 and above. Internal medicine will see more the 65 to 75. It really depends on the institution. It's a bit flexible in that sense. And as per the Royal College, it's the branch of medicine concerned with the prevention, diagnosis, treatment, and social aspects of illness in older adults. So what we do often is the CGA, or the Comprehensive Geriatric Assessment. And what that essentially is when we're seeing patients is completing the usual assessment that you would in internal medicine. So collecting all the things like past medical history, habits, allergies, etc. But then in addition, we do what I call a geriatric review of systems, and it includes these components. So we get a social history, which I'm sure you guys do as well. We focus a lot on their functioning. So really going through all of the instrumental activities of daily living, like finances, medication administration, and their basic activities of daily living, like bathing and toileting, and really get a sense of how they're doing each one. We go through their mobility. So specifically, do they have a history of falls? How many times have they fallen in the last year? Do they use gait aids? We ask a little bit about their cognition, particularly with collateral, and ask a little bit about mood, and sometimes do utilize screening tools depending on the situation. We ask about sleep. So not only are they sleeping too little, but are they sleeping too much? Is there daytime sleepiness? And then try to figure out if there's any sleep apnea symptoms or REM sleep behavior disorder type symptoms. We ask about their elimination, so in particular incontinence, urine, and stool, but also if there's constipation. And then we really dive into hearing and visual impairment. So hearing impairment, do they wear hearing aids, and are they compliant with them? Are they working? When was the last time they had their vision checked? And nutrition, we also screen as well. So often it's not enough to ask if there's been weight loss because they won't really know. And ways to kind of get a sense is if the clothes getting looser, is the belt getting tighter? Um, is what is their a day of eating look like for them? I usually ask them to explain to me what do you eat in the morning, what do you eat for lunch, what do you eat for dinner? And then in that category, we also ask, is there any coughing or choking when they're eating solids or when they're drinking liquids? So we collect all of this information plus the typical stuff in an internal medicine consult, and we form our impression plan, which typically constitutes the 5 M's. So mind deals with cognition. Is there a cognitive problem? Is delirium present or not? Is there a mood disorder? We comment on mobility. So if they're coming in for a fall, we'll comment on why we think they fell. And even if they didn't come in with a fall, we'll comment on their fall risk, what we found their gait to look like, should they be using mobility aids, and give some recommendation for falls prevention. We'll talk about their medications, so we'll review them in detail in terms of if they're appropriate or not, and if there's any medications that might be missing, and usually assess their renal and liver function to make sure the medication doses are correct. We comment on all of their comorbidities, their chronic ones and their new ones, and comment on how if they're being adequately managed or not, and give any recommendations if we feel the need. And then the matters most section really has to do with what's the big picture, what is their goal of care, where are they going to go from here if we're seeing them in hospital, for example, and how do we optimize their function and quality of life. So that's what we typically do for a CGA. And there's evidence for its utility across multiple settings. So in the surgical settings and on acute medical floors and in the community in terms of reducing delirium, the length of stay, mortality, disability and ADLs, nursing home admissions, and frailty. So we do this quite a bit, obviously. So the first geriatric syndrome I'm going to talk about is falls, which are quite common. Just to give you a sense, 1 in 4 people 65 years old and older falls each year. Every 20 minutes, an older adult passes away from a fall. So they can be very common and have serious implications in terms of injury and even death, and can be preventable, in 30 to 40% of cases. So we really want to try to identify those who are high risk and optimize them as much as possible. So what are some of the main risk factors? There are many, and the list can go on, but these are some of the most significant ones. So benzo use, dementia, evidence of previous stroke on exam, Parkinson's disease. When they're standing up, if you're seeing them holding onto the hands of their chair, that suggests proximal muscle weakness and is a risk factor for fall. If they've fallen in the past year, polypharmacy, and a lot of the psychotropic meds, unfortunately, that are used in psychiatry can contribute to falls. So there's many risk factors. And so how do we screen is often asking, have you fallen in the past 12 months? And to increase the sensitivity, we do 3 key questions in terms of identifying those at risk of falls. Is not only have you fallen in the past year, but do you feel unsteady when you're standing or walking, and do you worry about falling? And, all the patients we see in clinic, even if they're not coming for a fall, we typically screen them. And there are, just to highlight, certain fall screening tools that you can just print out. So this is from the State Independent Self-Risk Assessment. It's online. They have a website with all kinds of falls documents and information, and you can print out this screening tool, give it to your patients in the waiting room, and they can fill it out themselves. And a risk of 4 or more is associated with a risk of fall. A score of 4 or more is associated with a risk of falling. So these are ways that we can identify patients. And then the main guidelines for falls are the World Falls Guidelines. So these were published in 2022. And this is the main algorithm to be familiar with. So there's kind of 2 arms. There's an arm on the left where you're seeing patients for an unrelated reason, just a general checkup, or for another reason, and you're going to screen them for falls by either asking the 3 key questions or have they fallen in the past 12 months. Or on the right, you're seeing someone specifically for a fall. Okay, So if we focus on the left, individuals who are just screening, have you fallen in the past 12 months, 3 key questions. If they answer no, they're considered low risk. But individuals in the community who you're seeing just for unrelated reasons, there's still a 30% risk of 1 or more falls in the next year for these individuals. So primary prevention becomes important, and primary prevention also includes falls education and exercise. So for those individuals who are low risk, this is usually what we'll recommend is exercise as per WHO guidelines, 150 to 350 to 300 minutes, rather, of intermediate intensity activity per week, aerobic activity, and 2 or more days a week of doing muscle strengthening exercises, specifically strengthening more the proximal muscles. So types of exercises could be sit to stand, squats, Tai Chi is also good for balance, but you really want to focus on balance and strength exercises. And then all these individuals should undergo fracture risk assessments, evaluations for osteoporosis, which is kind of outside the scope of this talk. And then falls prevention we might focus on. So as I mentioned, would be exercise and balance, but also reviewing medications and stopping or reducing those that could contribute to falls, which we'll talk about. We usually ask for a home assessment by occupational therapy. And I don't think everyone's from Quebec. In Quebec, it's called the CLSC, but there's usually in each province a home care community program that can go, and they have occupational therapists that will assess the home, look for hazards. We ensure that their vision is optimized, referred to optometry, make sure they're up to date on their eye examinations. Look at the feet, always look at feet when we're assessing patients for falls, looking for ingrown toes, bunions, ulcers, etc. Referring them to a podiatrist if needed, or they can get fitted for proper shoes. And when you're seeing patients, your geriatric patients, look at what kind of footwear they're wearing, especially in hospital. They tend to bring whatever they wear at home in the house to hospital, and it'll be often slippers, things you just slip on. But really, for optimal falls prevention, they should be wearing closed shoes with proper grip at the bottom and a low heel. So that's important. And then if there's any vitamin D deficiency, then supplementing that. So those are for the low risk patients, how we try to optimize them. Now for the high risk and intermediate risk patients. So we're going more towards the right side of the algorithm. So patients coming in for fall or fall related injury, we screen them for fall severity. Okay, and that has severe fall is one that resulted in injury. They're considered severe fall risk if they had 2 or more falls in the last year, if they're frail, if they lay on the floor for more than an hour, unable to get up, and if there's been a loss of consciousness. And if there's one of any of these, then they're considered high risk for higher fall risk. If the answer is no, then we assess their gait speed, which I'll talk about. And then they may end up as low risk or intermediate risk, depending on their gait speed. So for the intermediate risk and high risk patients, we do what's called a multifactorial fall risk assessment. And then we tailor our interventions based on what comes up as risk factors. So these are all the domains that we assess in a multifactorial falls risk assessment: mobility, sensory function, activities of daily living, cognition, medications, disease history, autonomic function, nutrition, and environmental risk. Okay, so activities of daily living, it's as per usual. We really go through all of their functioning. You know, if they're having difficulty in the bathroom, showering, for example, due to mobility reasons, it's a tight space, they might have difficulty moving in that tight space, and there's an increased risk of fall. So we try to optimize their functioning as much as possible. Cognition is particularly executive functioning when their judgment's impaired, their judgment in terms of moving around in a space and judging obstacles, their falls risk is increased. You know, there may be not a lot we can do about that depending on the underlying cause, but we try to identify it. Medications, we review all of their medications and try to identify those that contribute to fall risk, which we'll talk about. And then we screen for malnutrition. There's different tools that you can use. For example, I wrote the MNA here, which is essentially the mini nutritional assessment. But you can also refer them to a nutritionist if you have concerns. And then we supplement vitamin D for pretty much all of our older adults. And then finally, environmental risk. That's when we send in an occupational therapist in the home and have them evaluate, are there rugs, are there obstacles that could be increasing falls risk, how's the lighting, and then try to optimize those factors. I'm going to go into a bit more detail for the other ones. So for mobility, there's a lot of things that you can assess for mobility. And in a falls clinic, we usually have a physiotherapist who's doing extensive assessments. For example, assessing their balance using tools like the Berg, their gait speed. So gait speed essentially is how fast they can walk in 4 meters. So we usually time it. And then their timed up and go, their tug. So the timed up and go is essentially from seated position, they get up, they walk about 10 feet, turn around and sit back down. How long does that take? And there's specific cutoffs that have been identified in the literature in terms of increasing the risk of falls. So if your gait speed is less than 0.8 meters per second, it's associated with an increased falls risk. And if your tug is 15 or more seconds, it's associated with an increased falls risk. So oftentimes in falls clinics, these will be assessed. And then they'll look at, just a strength examination as we usually do, just the power exam, hand grip using a dynamometer. These have been associated with falls risk if they're low or impaired. So all of these things are typically assessed in detail. And then are they using their gait aid properly? Because if they're not, then that might be associated with falls risk. So the walker should be held with the elbows bent about 15 degrees. And the cane, the top of the handle should come about the wrist, the crease of the wrist. And when they're holding the cane, their elbow should be at about 15 degrees. So when you're seeing patients in clinic, you can be looking, how are they using their gait aid, and maybe they're not using it properly. So that's mobility in a nutshell. Sensory functions, pretty self-explanatory. I mean, it includes not only visual impairment and hearing impairment, but also is there any vertigo? So when someone's coming in for falls, we usually ask, was there any dizziness associated with the fall? And that could be if it's, the room rotating and, it sounds very vertiginous and, you do a Dix Hellpike and it's positive, there might be an underlying peripheral vertigo that might be contributing. You might have to target that. Visual acuity in hearing impairment typically we refer to optometry and audiology if there's concerns that these are impaired and that they need to be optimized. And then disease history, that's really important because there are a lot of comorbidities that can contribute to falls risk. So particular cardiovascular disorders that can contribute to syncope if there's an arrhythmia or an severe AS, aortic stenosis, for example. We want to assess for those, auscultate the heart, plus or minus do an ECG and Holter, depending on the situation. Assess for any neurologic disorders, do an extensive neuroexam. They may have peripheral neuropathy, Parkinson's disease, etc., that might be contributing. Assess frailty, which I'll talk about a bit later. Depression in terms of can also increase the risk of falls, mostly due to some of the cognitive effects that can occur, and psychomotor slowing. And then pain, in particular, arthritis of the knees has been associated with falls risk. And so we always try to identify that. And then finally, autonomic function refers to orthostatic hypotension and urinary incontinence. So orthostatic drop of 20 or more in the systolic blood pressure, 10 or more in diastolic is considered significant. These individuals, we try to manage non-pharmacologically, increase their fluid intake, their salt intake, remove medications like blood pressure medications that could be contributing, make them wear compression stockings. And if those don't work, then we can add medications like midodrine, for example. And then urinary incontinence kind of falls under autonomic function, although it may not always be due to a dysautonomia, but we always screen for it. For example, within the last 3 months, have you leaked urine? Because urinary incontinence, rushing to the bathroom because you're about to go and have an accident, is associated with an increased risk of falls. So then we try to find the underlying cause and optimize if possible. And so for all of these high-risk individuals, in addition to identifying all of the factors that might be contributing to falls risk, we want to also emphasize exercise as per the previous recommendations. We want them to have a fall detector, a pendant, or something they wear around the neck that they can either press or that will just go off if they fall, especially if they're living alone. And then physiotherapists can teach them maneuvers I have here on the right, for example, on how to get up if they do end up on the floor so that we can prevent a long lie, which could be associated with rhabdo, dehydration, pressure sores, etc. And then finally, we target all of those fall risk factors we identified in the multifactorial falls risk assessment. So this, for example, kind of highlights all the things we might do. For mobility, if we see they're not using their gait aid properly, we might fix that. For sensory function, if there's a vestibular problem, they can do vestibular rehab. For medications, we'll deprescribe. I'll talk a bit more about the problematic medications shortly. Disease history, if there's an arrhythmia that could be contributing to falls, we refer them to cardiology, etc. So we kind of optimize all of these domains if something shows up. So that's falls in a nutshell. I'll quickly talk now about polypharmacy. So polypharmacy, there's different thresholds that are used, but most commonly we'll see is 5 or more drugs of different classes that they're on. That in itself is a risk for falls, but also confers risk for adverse drug reactions, which we want to avoid. Polypharmacy can be appropriate or inappropriate. It's inappropriate if the risk outweighs the benefit, and inappropriate polypharmacy increases the risk of ADRs, which is adverse drug reactions. And all our older adults and those who are in long-term care are at increased risk of polypharmacy. So adverse drug reactions, pretty self-explanatory. It's an unpleasant reaction to a medication. Can be difficult to recognize in older adults in the same way that a pneumonia in an older adult may present as a fall or delirium and without the clear symptoms of a pneumonia. An adverse drug reaction can present just as fatigue, cognitive impairment, constipation, and it may not be obvious that it's related to a medication. So when we review their meds, if someone's coming in for a fall or delirium, we always try to see if there's something new that's been added or a dose increase or potentially a medication that could be contributing. And these adverse drug reactions lead to prescribing cascades. So for example, an example of a prescribing cascade is, let's say, calcium or iron is started, then that can lead to constipation, and then laxatives are added to treat the constipation. So essentially more medications are added to treat the adverse effect of the medication. So we want to try to avoid that as much as possible. Older adults are at increased risk of adverse drug reactions due to changes in their pharmacokinetics. So they have a reduction in muscle mass and water content with age and a relative increase in the proportion of total body fat. So for example, lipophilic drugs like benzos will then have a higher volume of distribution, a prolonged half-life. It's more likely to accumulate. So for example, in patients who are coming in, or older adults who have alcohol withdrawal, usually those patients will end up with diazepam prescribed, but that has a long half-life already, an even longer half-life in older adults. So we might prescribe Ativan instead. So you kind of have to make modifications based on what we know the pharmacokinetics to be in our older adult population. And there's multiple different tools that I'll leave for you that you can use to assess polypharmacy in older adults. The most common ones are the Beers criteria, which I'm sure I wrote updated in 2019, but it's been updated since then in 2023, I believe, and stop-start. And there's also stop-fall, so medications contributing to fall risk. So stop-start, if you take a look at it, has multiple criteria, not only for medications to consider stopping, but also medications to consider starting, so medications that might be omitted. And it's separated by physiologic system. So for example, the nervous system suggests to stop tricyclics. as we know, in individuals with dementia can worsen cognitive impairment, and there's a whole host of side effects associated with this medication. So you can always turn to this tool. And Stop Fall lists a long list of medications that contribute to fall risks. So benzos, antipsychotics, benzo related drugs, like the Z drugs, opioids, antidepressants, anticholinergics, antiepileptics, etc. There's a long list of medications that can contribute to falls. And then on top of just highlighting the drugs that are at risk, for example, benzos, it'll tell you in which cases to consider withdrawal. So individuals who have daytime sedation, cognitive impairment, or psychomotor impairments. In which cases a slow taper is necessary. So for benzos, obviously a slow taper is necessary, and what to monitor after stopping the medication. So stopping or tapering off benzo can be associated with anxiety, insomnia, etc. So it highlights to look out for those things. The Beers criteria also comments on a lot of medications you guys will probably use in clinic in terms of what to be careful for in older adults. So they say it could be appropriate in REM sleep behavior disorder, seizure disorder, benzo withdrawal, alcohol withdrawal, severe GAD, and periprocedural anesthesia, but to avoid it in cases outside of that because of the risk of cognitive impairment, falls, fractures, delirium, etc. Antipsychotics, they say in older adults to avoid, except in schizophrenia, bipolar disorder, short-term use as an antiemetic for chemotherapy, and to avoid in BPSD unless non-pharm has failed because of the risk of CBA, cognitive decline, and mortality in patients with dementia. The Beers criteria also has a list of medication that increase falls risk, but it's a lot less extensive compared to Stop Fall. And that's pretty much what I wanted to highlight for polypharmacy. Just looking at the time now, we'll talk about urinary incontinence. So continence, pretty obvious. It's the ability to go to the bathroom when and where you want to go. And urinary incontinence is when you're involuntarily leaking urine. It's more common in women. It's very common in nursing homes. And the main thing to remember is that there's significant consequences. It can increase the risk of falls. They're rushing to the bathroom. They might fall, UTI, and isolation. They don't want to leave the house because of the incontinence episodes. And a lot of the patients will not volunteer this information because there's a stigma around it. So we always have to sort of screen for it. Do you have to wear pads frequently because you might leak your urine? Or do you feel a sudden urge to go that you can't control? Do you find you're not making it to the bathroom in time and you're having accidents, that kind of thing? It's important to pick up and try to optimize because it can have significant effects on health and also psychological well-being. So the main types of incontinence, there's stress incontinence, which is usually associated with pelvic floor muscle weakness, women who've had several vaginal deliveries or who've had hysterectomies and surgeries in that area, or individuals who are obese might have a weaker pelvic floor. So individuals with stress incontinence, they might cough or sneeze or laugh. There's an increase in pressure, and then suddenly they're leaking urine. Urgency is incontinence that's preceded by a sudden urge to void that's very difficult to control. And that's usually associated with the detrusor muscle, which is the muscle of the bladder, being hyperactive, either from a neurologic perspective or a neurologic abnormality, or due to an obstruction for whatever reason. Upstream, there might be hyperactivity of the muscle. You can have mixed stress and urgency. It's very common. Functional incontinence is when individuals have functional impairments leading to incontinence. So for example, they have mobility impairments and they can't make it to the bathroom in time. And high post-void residual is essentially overflow incontinence. There's an obstruction leading to eventual overflow. An overactive bladder is the symptoms of urgency with other lower urinary tract symptoms like frequency and nocturia, and they may or may not have incontinence associated with that, and it's essentially managed similarly to urge incontinence. So some of the medications, and I'm highlighting the ones that you will prescribe that can contribute to urinary incontinence or anticholinergics. So the parasympathetic system is what's responsible for voiding. So if you're blocking the parasympathetic nervous system with anticholinergics, then you might get urinary retention and overflow type incontinence. Psychotropic medications like antidepressants, antipsychotics, the ones that tend to be more anticholinergic, can have adverse effects, but also just by virtue of being sedating and affecting mobility, it can cause sort of like a functional incontinence type picture. So you want to be careful about that. And then the cholinesterase inhibitors obviously are promoting more acetylcholine, which essentially is augmenting the parasympathetic effect and can contribute to urinary frequency and urgency and thereby incontinence symptoms. So you want to be careful prescribing that medication in individuals who already have problems with urge incontinence, overflow, overactive bladder rather, and incontinence, because it can worsen it. So how do we treat these individuals? It's essentially based on the underlying etiology. So if it's mostly urgency, we try to modify their lifestyle, behavioral interventions, which I'll talk about, and may consider a trial of antimuscarinic drugs, but those can have side effects. So we'll talk about that. If there's overflow, if they're retaining and there's overflow, they might be retaining because of constipation, because of medication. So we try to optimize that. In men, it could be related to the prostate, so we give alpha blockers, and then they may require intermittent catheterization and eventually referral to a urologist if it's non-reversible. And stress urinary incontinence is typically related. Typically, the intervention is strengthening the pelvic floor muscle. So the lifestyle interventions we suggest is reducing water intake to about 2 liters or less, but to be careful in our frail older adult population because of the risk of dehydration. Treating constipation, optimizing and removing medications that could be contributing. Certain comorbidities can contribute to urinary incontinence, like obstructive sleep apnea, increases the risk of nocturia overnight, and then accidents. So we want to try to optimize those, improve their functioning. So if it's a functional incontinence, they're not making it to the bathroom in time, you can ask for, let's say, a commode at the bedside overnight so they don't have to get up and go to the bathroom. Obesity can contribute to stress incontinence, so they might have to lose some weight. And smoking is also associated with incontinence, so we counsel smoking cessation. And then there's different behavioral interventions that I'm not really going to go into detail on, but for example, stress incontinence, we might refer them to a physiotherapist to do pelvic floor muscle therapy. The pharmacotherapy that's available, so we have the antimuscarinics like oxybutynin, solifenacin. Usually we do not prescribe those and deprescribe those as much as possible because of the anticholinergic side effects. So I would advise avoiding those medications. But beta-3 agonists like mirabegron will not have an anticholinergic side effects, may have a small increased risk of hypertension, but doesn't really commonly happen. So for a patient who has urge incontinence, urge type symptoms, behavioral modifications and lifestyle modifications are not working, you want to try a medication, it's better to use mirabegron than any of the antimuscarinics. And then for the BPH enlarged prostate patients, alpha antagonists are often used, but those can be associated with orthostatic hypotension. So I'll talk about frailty for another 5 minutes or so, and then we can maybe do some questions. Frailty is kind of a big topic in geriatrics. One of the leading individuals who publishes on frailty is a Dalhousie. So it's a a lot of talk about it, especially in Canada. And what frailty essentially is an increased vulnerability to a stressor event, which increases the risk of adverse outcomes like falls, delirium, disability. So I think this graph on the right is the best way to kind of picture it. In green is an individual who's non-frail. They're independent, they have high functional ability. They have a minor insult like a urinary tract infection. Their functional capabilities might drop a little bit for a short period of time until they get better, and then they're back to their usual baseline afterwards. A person who's frail, like here in red, they, are hovering on that line of dependent, almost dependent for their functional abilities. They have the same insult, same urinary tract infection, and their abilities decline much more significantly during that insult. It takes them much longer to improve, and they may never return back to their previous level of functioning. So this is what it means to be frail, is the graph in red. Just like everything in geriatrics, it's multifactorial. Advanced age is a risk factor, low education, some of the demographics and social factors, clinical factors, so being multimorbid and having multiple chronic diseases, obese, malnourished, impaired cognition can all contribute. Lifestyle factors, particular low protein intake and low physical activity. And then biological factors, so chronic inflammation and micronutrient deficiencies like low vitamin D can all contribute to frailty. How do we assess frailty? There are two main methods. The first one is the frailty phenotype, which is assessed by weight loss, self-reported exhaustion using a particular scale. Low energy expenditure, again, calculated using special scales. Slow gait speed, the gait speed that I talked about earlier. And then weak grip strength. Using a machine, we measure the strength of their grip. And if they have 3 or more of those that are abnormal, then they're considered frail. So this is a little bit more complicated to do. Can't really easily do it in an ER environment. Usually done more in a clinic. The clinical frailty scale is the one that I would recommend remembering to assess frailty. It's pretty easy to do in that, for us at least, we can come up with the score after doing a comprehensive geriatric assessment because it's based on their function. So once they start having problems with their instrumental activities of daily living, like finances, housework, etc., then they start becoming at least mildly frail, a clinical frailty scale of 5. Once their ADL, basic activities of daily living, start becoming affected, like bathing, then they are more moderately frail, a clinical frailty scale of 6. And once they're pretty much completely dependent, it's a clinical frailty scale of 7. And then there's also a scale or a number for those who are end of life. And then the non-frail patients are a clinical frailty scale of 1 to 3. Those individuals are completely independent, but they may have more disease symptoms or have more mobility impairment when you're a 3 as compared to a 1. So this one is pretty easy to do. You get that information just from your usual assessments, and it should be assessed based on their state 2 weeks prior to their acute illness. So if you're seeing them for an acute illness, you're assessing them based on their function 2 weeks prior to the acute illness. And then what do we do for frailty? Because there's a lot of talk about assessing it. So what can we actually do? Really, the main things that actually have in the literature benefit for frailty are exercise, in particular resistance training, focusing on proximal muscles. That can improve function and mobility. And then the comprehensive geriatric assessment, both in the inpatient and outpatient setting, will have benefit in terms of functioning and improving their likelihood of returning home. So that's frailty. And then very quickly, elder abuse. I think we all know that there's many different types of elder abuse, physical, using intentional physical force to harm someone, sexual, neglect, financial, emotional, and then there's also the concept of systemic or institutional abuse, so which could happen in nursing homes, for example, like using restraints to prevent falls, or diapering an individual because it's, too difficult to get to them to the bathroom. Those types of things confer harm, and are avoidable, and so they are a form of abuse in a way. So, things to look out for: physical abuse, in particular jaw and zygomatic fractures, won't typically happen from just falls, or dental fractures won't typically happen from just falls. It might be a sign that it's related to a physical abuse. Sexual abuse, you're looking for lacerations, abrasions in the genital area, new sexually transmitted diseases. Neglect can look like poor hygiene, dehydration, decubitus ulcers. Financial, they're not able to pay for their necessities, renew their prescriptions. They're more malnourished because they're not able to access food. Those are some of the signs to look for. And emotional, they might appear intimidated, deferring questions to caregivers, and they might be more isolated. And then in terms of what you do for abuse, I mean, it really depends province to province. So I'm not going to go into detail for that, but these are some of the things you might look out for. And then usually every province will have an online website to consult in terms of how to approach potentially the need for what's the word? Disclosing that there's abuse to the necessary authorities. So that's the main things I wanted to talk about in terms of the geriatric syndromes, geriatric medicine in a nutshell, that might be relevant to you. I don't know if there's any questions.
I'm curious about how, like something I've been thinking a lot more about is how, like obesity can still be malnutrition,
Mm.
and then how that would
Oh,
assess like malnutrition other than.
sorry, you're cutting out. Can you hear me? Am I frozen? You can't hear me?
Yeah, we can hear
Oh,
you, Patricia.
oh, okay. Yeah, she's frozen for me.
Did you get the gist of her question? I think she's maybe asking about what's perhaps some lab tests, et cetera, that you would suggest in terms of determining whether there's malnutrition in somebody who's overweight or obese.
Yeah. So there's this concept of sarcopenic obesity. So they might be, if you calculate their BMI, it's elevated, but in addition to being overweight, their muscle mass is low. As we get older, we lose muscle mass, but also more likely to become sedentary. And then muscle mass diminishes in addition to that. So they can have a low muscle mass while being obese. And so those individuals can still be malnourished in terms of their protein intake, in terms of the underlying nutrients that are necessary to build appropriate muscle mass. So how the best way to sort of assess patients, an albumin is not going to be necessarily helpful because the level can remain elevated for several months. So you might do it, it looks normal, but then it takes about 3 months to see the level actually drop. It can also be affected by acute inflammation, so it can appear low in the context of an acute inflammatory episode. Let's say they have an infection. So albumin is not helpful. Usually pre-albumin is what I would suggest measuring. It's a more accurate marker in terms of protein levels at the moment compared to albumin, which is more a measure of in the last 3 months. So if their pre-albumin is low, that gives you a better sense of of malnourishment than albumin. And then for our obese patients, you want to also measure their muscle strength to identify sarcopenia. So that might be more difficult for you guys to do in a clinical setting, but in our outpatient clinics, we might measure their grip strength, or we might measure their proximal muscle strength by measuring how many times they can get up from seated within 30 seconds. So that's a chair rise test. And if it's low, there's specific cutoffs based on being male, female, and your age that might suggest that there's proximal muscle weakness and there's sarcopenic, meaning their muscle mass is low. So there's what we do in the outpatient setting, the more specialized testing, like for proximal muscle weakness and grip strength. But for your purposes, I would try to get a sense of what is their intake like in a 24-hour period. Are there concerns that it might be insufficient? In particular, protein. Protein is very important. We want them to be getting about 1.2 grams per kilogram per day. In older adults, that we want higher protein intake. And you can order a prealbumin as a more accurate measure of malnutrition.
Thank you so much.
Problem. Any other questions?
I don't
Can't see
see any questions
Yeah.
coming up in the chat.
I just had a quick question.
Sure.
Just wondering what your recommendations would be for like pain management in older adults. I'm just thinking like we have a patient on the unit now who was on Tramadol when she came in, but she was like a little bit delirious and things. So they ended up switching it to like regular Tylenol arthritis kind of thing and like topical pain management. But she can't take NSAIDs because of a bleeding disorder. So I'm just wondering like what would be kind of the safest option, and but her pain's not very well controlled now. I'm just wondering kind of like what you normally recommend and what would be the safest options for pain control in older adults.
Yeah, I mean, it's tricky because a lot of the medications will have side effects. It kind of depends on what the underlying type of pain is. It's kind of different approach. If it's more neuropathic pain, you might have different options. But in general, I mean, most often we'll deal with like MSK, osteoarthritic type pains. All of our patients who have pain, we put them on regular Tylenol. Usually you want to try to avoid going higher than 2 to 3 grams in a day. So the typical dose we'll do is 650 milligrams QID. And Tylenol just works better when it's being given regularly for several days as opposed to taking it on a PRN basis. So often patients will say to me, I've tried Tylenol and it didn't work. Well, they just took it PRN and they weren't really taking it regularly, and there's benefit to getting sort of that steady level. So that's always the first step. Then the second step, obviously, NSAIDs. Typically, we can't give them because they have contraindications. So I would say most of the time we avoid them. If pain is still poorly controlled, and let's say it's a joint, an osteoarthritis, could we give an injection locally to try to control the pain? If it's in the back, spinal stenosis, could we also try a local intervention to try to optimize the pain? So local interventions could be an option. If not, a low dose narcotic, depending on the situation, could be tried, because you're always weighing that risk benefit of poor pain control can obviously have effects on cognition, increasing the risk of delirium, etc. So usually we go for dilaudid because it's just the safest in the context of renal impairment, which tends to be an issue in older adults. And I would start 0.25 milligrams for these patients, starting very low. And for as infrequent as possible for as short as possible. If there's a neuropathic pain component, you can try medications like pregabalin or gabapentin at low dose. And then a medication I prescribe often for pain, if it's related to osteoarthritis or even neuropathic pain, is duloxetine, because of that additional pain effect. So those are the kind of general approaches, and obviously it can become quite tricky. We have here in Quebec geriatricians who are specifically trained in pain, and who really have more expertise in terms of how to, weigh the risks and benefits. So I'll often refer to them when those initial steps aren't really working. But yeah.
Thank you. That's really helpful.
Also, sometimes they can become quite stiff if they're not using the joints, or if that's the place that's hurting. So doing exercises and physio might also be helpful for pain.
I'm just curious. I know you mentioned like using duloxetine for neuropathic or OA pain, and I was wondering, is there any evidence for like pregabalin or gabapentin for OA in the context of like over time those joints like rubbing together excessively, the nerves are going to get inflamed, and there could be a potential like component?
As far as I know, no, it's not from the guidelines. When I've last reviewed them, there isn't really much evidence for the use of pregabalin, gabapentin. There is also evidence for topical treatments like capsaicin cream for OA type pains and Voltaren. So you could use NSAIDs in topical form because there's less systemic absorption. But in terms of gabapentin, pregabalin for OA pain, it's not typically used.
Okay, I don't see any other questions coming up or anybody kind of raising their hand or coming forward, but thank you very much, Dr. Pavoni, for a really comprehensive presentation. I hope it was helpful for the residents. I'm sure it was.
Thank you so much. Have a good day.